process. We were absent a microphone today, so if you can't hear at any point, just let me know. I'll let you know. We're very excited to welcome Dr. Chad Watkowitz of Urology Associates of York Hospital. He's going to be presenting today. He joined us nearly 2 years ago from Lakey Hospital and Medical Center in Burlington. He's board certified by the American Board of Urology and is a graduate of the University of Massachusetts Medical School. Dr. Watkowitz completed his internship in general surgery at Lakey Clinic, where he also served as chief resident in general surgery and urology. Following his presentation today, he's going to be happy to answer any of your questions. Thank you.
I'd first like to thank the hospital for giving me the chance to speak today, and also all of you people for missing a lovely afternoon to hear about this talk. But before going to UMass, I'm a native of Western Massachusetts. I grew up in the Berkshires. I went to Johns Hopkins for a couple years, and then I went to Boston University following that with aspirations to be a transplant surgeon. And then I worked with one of the transplant surgeons out at UMass who was a urologist, and realized that the lifestyle was a lot better as a urologist, and since then we've gone down that road. Personally, I'm married. I have 5 children. I have 2 daughters who are going to be seniors in college next year, a son who's going to be in Germany studying classical music, and our 9- and 7-year-old children at home that keep us pretty busy. So that's me. So I specialize in just about everything you possibly can in urology as a general urologist. Some areas we are a little bit extra trained. My partner, Dr. Baumgart, who I do most of my surgeries with respect to urogynecology and oncology. But we do deal with erectile dysfunction, female incontinence, pelvic organ prolapse, kidney stones, laser treatment of the prostate, overactive bladder, all the forms of oncology that you can think of, and I specialize a little bit in fertility myself. Today we're going to talk about 2 topics. The first is going to be stress incontinence and pelvic organ prolapse. Obviously that's going to affect the majority of females here, although men do have stress incontinence in some situations. And then if we have a chance, we'll get to some BPH topics. That's also going to be covered in October when I give another talk with more of a men's health focus. Okay. So we have 3 types of incontinence. I have a pointer here. Our bladder leakage. There are stress incontinence, where if you cough, laugh, or sneeze, you leak urine. There's urge incontinence, although it's not listed up there, where you feel the urge to go to the bathroom, you try to hold it, and you can't make it to the bathroom in time, and your bladder decides to empty without you having any control over it. And then the third is the mixed incontinence, where you have a combination of both. We'll talk about stress incontinence here, essentially a brief overview, some treatment options, and also the pelvic organ prolapse treatment options and evaluation. I'd like to thank folks from AMS who provided me with the slides here. They have some of the best products in urology that we use, and we'll continue to use them during our treatment for all of our patients here. Bladder leakage is a very simple term. It's the loss of urine involuntarily, whether under control or not under control. If you wake up in the morning or during the day and you have a wet pad or undergarment, that's leakage. There's nothing else that causes that. 1 in 3 adult women do have incontinence. About 75% of incontinence, based on studies, is treatable. Just the difference between treatable and curable. Things are curable when they're taken out and completely resolved. A lot of oncology cases, we cure cancer because it's resolved and removed. Treating incontinence is on a gradual basis. Some patients may not become 100% improved, but if you move somebody up 50 to 75%, and you look at their quality of life for them, that's considered curing them. Younger patients will tend to have a higher cure rate for incontinence. That's because they've let the problem go on for a shorter period of time. Like most of us know, bad habits are hard to break. If people let incontinence stay with them for a long period of time, it's going to take a while for us to get them better. Less than 50% of women who have incontinence will talk to their primary care provider about this. Interestingly enough, I'll take a hit for our profession. Only about 40% of providers will actually ask you if you have incontinence during your yearly annual exams. So both parties are at fault in the situation. I would say that about 10% of the patients that I see for non-incontinence problems, whether it be kidney stones or other forms of oncology or infertility, they'll come back for follow-up and we'll talk about the stones. And they'll say everything's fine, but I just want to go over some paperwork. When I first met you, you didn't go over my incontinence questionnaire. And that just skipped my mind because I was focusing on what their main problem was. So I'm just as guilty of it myself. The reasons why most women, and I'll say men as well, because they feel embarrassed about the situation, or oftentimes they'll take it as being socially acceptable. My favorite lines are, I wear pads, but all women do that at my age. And I can guarantee you that a lot of clothing wardrobe changes from whites to blacks as we get older, just with people leaking. It really is a big issue. The amount of money that's spent on incontinence products and healthcare is in the billions. And that's amazing considering about half of it's probably treatable. These are the three types we already spoke about earlier. Essentially, the urge to go is a very strong sudden contraction where the bladder spasms under no control. Stress incontinence is where we cough, laugh, or sneeze, and the pelvic muscles, which keep everything nice and tight on the inside, are lax, and therefore we have leakage of urine. And then mixed is a combination of both. The main goal as a urologist, or if you see a urogynecologist in the community, is to differentiate the two, because the treatment options really are very different, and we'll talk about those as well. Of the 1 in 3 adult women who have incontinence, here's the generalized breakdown. About half of them have stress incontinence, a third will have mixed, and urge will only be in about 10% of the population. Helping to differentiate what causes this is why you come to a urologist or a urogynecologist. Cystoscopy or other procedures called urodynamic testing allow us to differentiate how the bladder is functioning, how is it filling up, and how is it emptying it out. And that's what we do over at office at York. So urge incontinence, as I spoke about, is the inability to hold it when you have to go. There are a lot of triggers to this. Some of them that I commonly hear are running water makes people go to the bathroom in some situations. You get near the bathroom. Most men get in the bathroom as we get older. We get a little bit of called functional incontinence. We're trying to unbutton our pants and take everything out, and it just doesn't happen. We leak urine. And some people, triggers are actually getting into their home. As soon as they come to the house, they feel like they have to go to the bathroom. So rather than just show you the slide, I'm just going to draw you a little picture here. What does it mean to have urge incontinence? They don't have a slide for this, so I'm going to come over on this side here. So this is your bladder right here, and this is your spinal cord and your brain. This is the innervation of the bladder and how it functions. So over a period of time, your bladder is going to start to fill up with urine, like so. Usually this takes about 2 hours, and you get about 1/2 of a liter of urine. As it fills up, we have receptors in the bladder. These are called stretch receptors. And what happens is at a certain point it reaches a threshold. The threshold for most people is to make a socially excusable, to go to the bathroom. At that point, the message will go down to the spinal cord. From the spinal cord, it goes up to the brain. From the brain, it comes back down and around. Okay? So people can have a problem anywhere along this pathway to cause issues with incontinence. The majority of the stuff that I deal with is at the level of the bladder. So urge incontinence occurs if the bladder only fills up halfway. In patients with overactive bladder for urge incontinence, the signal gets transmitted at a lower volume. We also know that when it gets transmitted, it can transmit it at a higher amplitude. So the rate going back and forth is greater. It basically means you have less time to be aware of going to the bathroom and less time to get yourself ready to hold it. Medications we'll talk about work at the level of the bladder by blocking some of these receptors, so it gives the bladder more time to fill up. Some people may have heard of Ditropan or Vesicare or Detrol. Common ads right about now at daytime TV, because most women, when watching TV, are over 60. That's the OAB population, so that's where we see a lot of the marketing. Patients who have spinal cord injury patients, neurogenic type bladders, we deal with a lot of these patients. A lot of guys coming back from overseas have a lot of injuries from the new IUD devices, which are causing a lot of lower spinal cord injury patients. They don't have any regulation of their bladder. I mean, it's very sad to see these guys living in wheelchairs, but they'll all tell you the same thing. Their main problem in life is the fact that they have no control over their bowel and their bladders. That's because they have no regulation in the spinal cord. As we get older, we can have Alzheimer's, we can have a stroke, we can have Parkinson's or dementia. All these diseases essentially work in a negative manner by telling the brain that it's okay to go to the bathroom. Your brain constantly tells your bladder to be continent. Okay, it's always on the off system. These triggers which go back up from the bladder to the brain turn that off. Alzheimer's and dementia basically allow the signal to be transmitted down without any relief from the bladder. So that's how some of these diseases affect a lot of patients. Almost 50% of people in nursing home will have a problem with their bladder. If anybody has any questions, just raise your hand. Okay. So the treatment options for the urgent continence are medications. There's two brands. There's anticholinergics and beta-3 agonists. They essentially let the bladder here fill up, okay, without as much pressure being transmitted to these receptors. They have a lot of side effects. They can be called constipation, dry mouth. Most patients who are on medications have dry mouth already. And constipation in the elderly patient population is a very big problem, as you're going to see. Dietary changes, essentially what that means is decreasing the caffeine or alcohol if you use that. Those are both diuretics, and those will make you go to the bathroom more often. Bladder retraining. Fortunately, I wish I forgot to, but Leslie Parker, who's an excellent pelvic floor physical therapist, maybe some of you have heard of her. She has offices in Elliott and Dover. She strictly deals with pelvic floor physical therapy, and she's just a wonderful asset to the community. Everybody that goes to see her always comes back with nothing but positive comments, and we'll talk a little bit about that as well. For the women, you know that when you're pregnant, they tell you to do the Kegel exercises. It's very simply pee, or when you're moving your bowels, to close all the muscles up together, to basically strengthen the pelvic floor. Biofeedback and electrical stimulation and surgery, they're a little bit more complicated. The surgical stuff that we do for urgent continence is similar to a spinal cord stimulator for patients who have chronic pain syndrome. We introduce electrodes into the nerve roots and basically reboot the system. A little bit too much for this topic today, but sometimes as you go down the road, patients do have to undergo these procedures, and they do benefit from them greatly. And the majority of urgent continence is and should be treated by primary care physicians because of its prevalence. It's usually when patients have failed multiple medical therapies that they come to see a urologist. We'll go over some of the other potential options with physical therapy, and then we'll proceed to usually do some surgical therapy. Although we don't have it here, Botox, which seems to be being used everywhere, is also used in the bladder now. So we do that as well. It's a different type of Botox party, though. So mixed is the combination of both, and we can treat the urgent continence with medication and stress incontinence with surgery. There are no medications that can help you with stress incontinence. Nothing's going to be able to keep your bladder from emptying out if it has to. Okay. So the definition of stress incontinence is very generic. It's the urine loss during exercise, coughing, sneezing, laughing, or any body movement which puts pressure on the bladder. That's just, pretty common knowledge right there. The risk factors, although there are many listed, some of these I agree with and disagree with. Age is not a risk factor for stress incontinence. There are plenty of 80 and 90-year-old women who are not having stress incontinence. Pregnancy, some studies suggest that if you have 3 children vaginally, irrespective of the size of the child, you're going to have about a 25% risk for some transient incontinence after your deliveries. Prolonged labor is another big problem. Not so much because of the size of the child at all. It's actually because of the amount of stress that the woman puts on the pelvic nerves when she's trying to push the baby out, and it causes a neuropathy, which is transient in those nerves afterwards. Those women do great afterwards, just letting the nerves recover. If you're overweight or have a high body mass index, obviously you have more weight on your intra-abdominal contents, which puts more weight on the top of the bladder, which basically subjects the bladder and the pelvic floor to a lot more stress. A hysterectomy, which is the removal of the uterus. The ligaments that suspend the uterus, which have to be sacrificed to remove that organ, also partially help to support the bladder. So it's not uncommon for patients to have a hysterectomy, and then a couple years later, they'll develop some stress incontinence, or we'll talk about later some pelvic organ prolapse. Physical activity is a plus or minus. if you're in good shape and don't have stress incontinence, that's great. But if you're trying to exercise and do strengthening for your whole body and your core, when you do core exercises or you do any heavy lifting, you're bearing down, and when you're bearing down, you're also exposing your pelvic floor to a lot more stress. So it's kind of a catch-22 when you're doing physical therapy and exercise. Smoking, that's pretty simple. Everybody coughs who smokes, that's why they get stress incontinence. Family history, everyone will say that their mother had it or their aunt or somebody, but there's no definitive clinical studies that have documented that if your mother has incontinence or prolapse that you will. Diet, this is just patients who are constipated. That's essentially all that means. And medical conditions can expose you. Some of these patients may have had other pelvic surgeries, or they may have had some radiation, which can also affect the natural muscle fibers in the pelvis, and those will also contribute to leaking. Non-surgical treatments for pelvic floor physical therapy, like we spoke about, those are more than Kegel exercises for the ladies in the crowd. It's more than that. It's biochemical feedback. Kegel exercises, if you look at, we don't have a formal pelvis here, is simply squeezing the sphincter muscle around the urethra. When you do formal pelvic floor physical therapy, there are about 6 or 7 groups of muscles within the pelvis that form a bowl. And by training yourself to contract all of those in a basically concerted fashion, your rate of decreasing the incontinence goes up significantly. And that really needs to be done with a specialist who deals with that, like Leslie or someone else in the community. Bladder training is simply, if you wait too long to go to the bathroom and your bladder's full and you cough and laugh or sneeze, you're going to leak more. That's pretty obvious. The tank is full, so just go to the bathroom every 90 minutes. So if you do have an incident, it'll be less. And prompted voiding is a similar situation. Surgically, open retropubic suspension, some of you may have heard of that. That is very rarely, if ever, done anymore. Almost all surgery that we do for incontinence and prolapse is minimally invasive through the vagina, some of it which is day surgery. And we'll talk about the slings. Everybody talks about someone had a sling and they're good, or someone had a sling and there's a complication, and we'll go over those too as well. So here's the body before stress incontinence. Although it's not highlighted, between the pubic bone and the anterior portion of the urethra, posterior urethra, anterior vagina, vagina rectum, and rectum back, this is the whole layer of those muscles I'm talking about. Okay, that makes up the pelvic floor musculature. Now, the bladder stores the urine. This is the muscle fibers around the sphincter. The urethra is the tube which passes the urine out. And when the pelvic floor is strong and you cough, laugh, or sneeze, all those muscles contract. And what actually happens is the pubic bone acts as an anchor or background. And what you do is the urethra gets pinched up against there. A girl in her 20s who has 8 or 900 cc's in her bladder, you can ask her to cough as hard as she can. And her muscles are so strong that that pubic bone will just pinch right up against the urethra and there'll be no leakage whatsoever. When you get stress incontinence, what happens is it's pretty simple. These muscles are lax, which I spoke to you about, although they're not depicted in this diagram. And there's nothing to basically suspend the urethra up against the pubic bone. As such, any intra-abdominal pressure from coughing or laughing or sneezing is going to be transmitted to the bladder, and that's going to overcome the urethral resistance here and lead to leakage. I call this the no-squeeze phenomenon. You have nothing there to help you support the urethra. So we talk about slings, and that's what we'll talk about here. So slings are very common, and all the procedures that we do as urologists or urogynecologists, this is probably the most satisfying, and the fact that the cure rates are, they say 90 to 95, I quote more about 80 to 85% for myself. The incisions are in the vagina. There's a small area that's dissected out, and then we make 2 other small incisions in the abdomen. I don't have all the diagrams. The mesh is inserted through the incisions and acts as a cradle behind the urethra. And I think the next slide depicts this. The mesh that we use for slings for incontinence is not the same mesh that's in the news and in the FDA and under all the lawsuits. It's a totally different product. The mechanism of action is totally different, and the rates of complications are significantly lower, such that we rarely, if ever, hear about major problems with urethral sling lawsuits. The mesh, which actually I describe as a piece of lattice, what it does is it sits behind the urethra and it acts as a scaffold. Your body doesn't like anything that's foreign that's in there. So we want that to happen. We want there to be a reaction to it with the immune system to build up a scar. Because that's really what you're lacking there, is that strong supportive tissue. So by recreating a scar, you're going to help to recreate the support from the urethra. And this is what the picture looks like, if you can see on the bottom here. So the sling goes behind the urethra, which is depicted here, and it's basically suspended up outside the pubic bone, and we pull up on it, and it helps us to maintain or improve incontinence. These have been around for a long time. This is 1968. I didn't even realize that. That was before I was born. Patients, after the procedure, I don't know if any of you had one here or a family member, the most important thing for all patients who have surgical treatment for stress incontinence is they cannot do any heavy lifting. The mesh needs to stay in the correct position where we wait about 6 weeks for a scar to form, which is similar to if you had a cut or a wound. In a week, if you took the scab off, it's going to keep having problems. So you want your body to be able to take a long time for the scarring to form. In the meantime, you can do activities which we say 20 pounds is about as much as you can lift. I don't think any insurance plan does not cover this, to be quite honest with you, so there should never be an issue with insurance. A couple of the other procedures that we do are the minimally invasive ones. Some of these we are actually doing as day surgery, so a woman can come in the morning and she'll go home in the afternoon, sometimes with or without a catheter. These rates, like I said, show that most of the procedures have about 85 to 94% continence rate. This is actually within a few days, which is excellent. Personally, I also send all of my patients to see a pelvic floor physical therapist before the surgery, just to get them in the best shape as they can, and after the surgery as well. There's nothing that pelvic floor physical therapy cannot benefit, both men and women, if we're talking about stress incontinence. Most men, of course, if you have or you know someone who's having, it's after a radical prostatectomy. Prostate's removed for prostate cancer, the sphincter muscle is often compromised, and that can lead to incontinence. Some of the risks of these procedures, I feel you have to disclose these to all your patients. If you don't, you'll be the unfortunate one that will occur to. But pain and discomfort can occur. There can be inflammation. That's actually what you want. You want there to be inflammation. You want there to be some swelling in the area that you're operating on. You want the body to be reacting to the foreign material to reform that scar. Infection, that is rare unless you have the mesh which erodes through. A lot of mesh erosion and extrusion, in my opinion, is either poor surgical technique or poor surgical candidates. Some patients, although the degree of incontinence they have is so severe that they're constantly wet, they're just not good candidates. Their wounds are not going to heal. They're going to be high risk for anesthesia. And those patients, unfortunately, will have to live their life with a catheter or an SP tube. They're just going to end up causing more problems when you operate on them. As far as the procedures, I'll be very upfront about this. Some organizations will say that you can go to a weekend course and train on a cadaver and be signed off on doing these procedures with a proctor for 3 or 4 cases. That's not AMS's policy, but that's just some hospitals' policy. And my partner and I, we train extensively as residents, and we don't abide by that. So I think if anybody or your friends or family members are going to have a sling procedure or any pelvic organ reconstruction, you really have to ask that surgeon how many they've done. And if they can't give you a number over 50 or 100, then you should really question that you're going to the right individual, okay? Because those are the patients that are having the problems with the complications down the road. Foreign body allergic reaction to mesh, we don't see that too often, and we don't see the scar tissue as well. Also, you can have retention. So this is the one problem which, if you put a sling in and you put it in too tight, the women think it's great. It's not. You're in retention, and you have to catheterize yourself. So in the past, we would give patients, a couple of months. We'd teach them to catheterize, or we'd actually go in there in the operating room and try to pull the sling down. Now we know that if we go back in within a couple of weeks and actually just cut the sling in the middle of the hammock, it still retains about a 60 to 7% efficacy rate. So that's one thing that you have to be aware of as well. Anytime you put a foreign body into somebody, there's going to be a reaction. At the level of the bladder neck where the sling goes, that's also the components here. When your bladder fills up and you have another urge to go, down here is where a lot of the receptors are. So when you put a piece of mesh here, you can sometimes get some scarring that will actually inadvertently sort of activate those receptors. So patients can develop some de novo or new onset urge incontinence after having had their stress incontinence dealt with. We see that about 5 to 10% of the cases, and we can manage them with medications. Wound dehiscence, again, that's, in my opinion, that is who are you going to operate on? You have to have good surgical candidates and make a good surgical decision, or else this is going to happen more often than not. Nerve damage is really not as common because of the new mini-arc procedures, where we basically can even avoid going outside of the pelvis, which helps out quite a bit to reduce complications. There are obviously nerves and vessels everywhere in the body, which can be damaged, and then there can also be bleeding that can occur in pain during intercourse. Oftentimes the pain during intercourse is patients who do not wait long enough after the procedure. So what can patients do? I mean, I think we all know about stress incontinence. It's very simple. It's leaking when you do any activity. Talking to your physician is probably the easiest way to get you to see a urologist or a urogynecologist. At that point, an evaluation will take place. In our practice, it's a pretty standard protocol that we have. Everybody will come in, they will get a pelvic exam, they'll get a cystoscopy to look inside the bladder to make sure nothing is abnormal. They'll get a voiding diary so we can really document how bad your voiding incontinence is, which is very important. And then we do a urodynamics test, which basically tells us how your bladder functions. The voiding diary is something that we really want you to have as soon as you come in. In some practices, before you even come in, you can fill it in online. There's also a lot of apps on your phones you can use nowadays just to see how you're progressing with the treatments. So pelvic organ prolapse is another area that we deal with. This is a commonly termed a dropped bladder. It occurs that when the tissues that hold the pelvic organs in place become weak or stretched out, and we see a prolapse. Basically, 1 in 2 women suffer from pelvic organ displacement or prolapse. This is more common as we get older as well. The symptoms can vary. They can affect a whole host of your work performance, sexual activity. Oftentimes, the primary complaint is the woman will simply say, "There's a bulge in my vagina," which means that her bladder has dropped down into the vagina. There can be a pulling or stretching feeling as well, and pressure or irritation. A rectocele is basically where the posterior aspect of the rectal wall falls into the bladder. Women will complain of primarily women will complain of not being able to empty out their stool or their vault. They'll sometimes have to disimpact themselves, or they'll manually put their hand in the rectum, in the vagina, to push the stool out. The stream is slow because the bladder is below the pubic bone, and I think we have a picture up there. And obviously, when you have any organs prolapsing into the vagina, intercourse is one of the other primary complaints that patients will have. Risk factors for prolapse are pretty much the same as in stress incontinence. Pregnancy will place you at risk. The number of childbirths you have. Menopause places you at risk mainly because as estrogen levels drop down, the actual integrity of the vagina or the introitus is decreased. So that also leads to some stenosis, which can also preclude you to having dropped organs, bladder, rectum. Previous surgery, mainly a hysterectomy, is the one that we look to. Being overweight, I don't agree specifically with aging, except in certain populations that's the case. In genetics, I think there's still a lot to be said about that. There are 4 types or 5 types. Cystocele is where the bladder actually pushes down into the vaginal wall. Oftentimes women will go to the bathroom, they'll get up, they'll put their pants on, and they'll sit right back down again to go to the bathroom again, or they'll lean forward to try to adjust the anatomy and get the bladder out. An enterocele is where the small bowel actually protrudes down. That's not seen that often. It doesn't really have too many symptoms. The bowels often don't get obstructed or strangulated like in a hernia. A rectocele is where the rectum protrudes out into the vagina. Again, that's common with constipation or obstipation, which is the inability to remove the stool, and patients, unfortunately, will have to disimpact themselves. A uterine prolapse occurs when the actual whole uterus, the cervix, falls right down out of the vagina. And a vaginal vault prolapse occurs where basically the whole entire vagina basically everts itself like a sock if you're taking a sock out. So this picture here demonstrates a cystocele. If you can remember the other picture, the posterior wall of the bladder was nice and flat against the anterior wall of the vagina. In the situation here, the bladder is falling down out into the vaginal introitus. Patient goes to the bathroom. This component of the bladder doesn't empty out. It's called the post-foot residual. These patients often have accompanying weak pelvic floors, so every time they laugh, cough, or sneeze, they always have some fuel in the tank, we say, and they're always going to have some leakage afterwards. Rectocele is a similar principle. It occurs on the other side of the posterior wall of the vagina. You start to see the bulge coming out here, and basically this area here becomes impacted. This actually will tend to fall a little bit more than that. So constipation is the major problem here, because as you're trying to push out hard stool, you're pushing and pushing and pushing the stool out the anus, but you're pushing and pushing and pushing the rectocele further out into the posterior wall of the vagina. A vaginal vault prolapse, like we spoke about, is actually the prolapse of the whole entire vagina and the cervix coming right out. Treatment options for pelvic organ prolapse: physical therapy and Kegel exercises will only really strengthen the muscles around the urethra. Okay, they're not going to help you when you have an actual defect in the anterior or posterior wall of the vagina. So pessary devices, that's a good option for a patient who's a non-surgical candidate. Some patients do very, very well with them. And I offer a pessary to all patients that come to the office with one of the gynecologists to be fitted, and we do the same as well. And the main goal as surgeons is to repair or correct the pelvic organ prolapse. So there's a couple of reconstructive techniques that have been around for a long time. There's something called the vaginal or anterior colporrhaphy, where essentially what we do is we dissect out the prolapsed organ, whether that be the rectum or the bladder, and we sort of recreate the side tissues over them. It's like a belt going over the top. A sacral colpoplexy is a procedure where they actually will do a laparoscopically or robotically, and they'll actually take that area that's prolapsed and they'll actually tack it all the way back into the sacrum. I don't know if you have that picture back there. So behind here is the sacrum. And this is a sagittal image. They'll actually take sutures and tack organs back to the sacrum here to help with that. And then transvaginal mesh repair is what my partner and I specialize in. We've been trained in this since residency, which was about 7 years ago for our female gynecology rotation. The product that we use is Elevate. There are a host of other ones. We've sort of been trained on this, and we've used it now for 7 years, so we feel very comfortable with it. It's minimally invasive. Again, it's all done with vaginal incisions, so you really don't have any abdominal scarring. The pain is a lot less than obviously having a midline incision for an open procedure or having a robotic procedure performed. These steps will just go through this quickly, but essentially you make another incision in the vagina where it's either the cystocele or the rectocele, and then that tissue is exposed, and then the mesh is supported and basically recreates those ligaments, which sometimes are lost after hysterectomy, and the incisions go. Typically about 90% of women are very satisfied with the results after we do the repairs. So again, for these procedures you need to talk to your physicians about it. The other thing is that a lot of women stop getting pelvic exams as they get older because they're told that they don't need to. But you need to have a pelvic exam every year. You really do. It takes 2 seconds, and you're going to find a lot of patients will have a lot of problems that are related to prolapse, specifically their voiding and their bowel dysfunction, that medications and regimens and fluid management are going to do nothing for you. It's a surgically correctable problem. And all these things are covered. So the risks are very similar. You can have adhesions, you can have bleeding, you can have constipation, you can have a failure where the prolapse occurs, you can have pain because of the mesh. Again, you can have prolapse from another organ, or you can have incontinence, foreign body reactions and mesh. Erosions. Again, they can erode into anything and the mesh can migrate. You can have nerve damage. You can obstruct some of the tubes coming down from the ureters. Specifically, my partner and I always do cystoscopies during our procedures to make sure that everything's okay with the ureteral collecting system, perforations, and urinary tract infections, voiding dysfunction, and wound dehiscence. this is really like every possible complication, and it take you a while to accrue all these in your career. So the condition is prevalent. 1 in 2 women have it to some degree. A lot more women have it very severely. They do need to be treated. It's going to lead to a lot of urinary tract infections and problems with their bowels. So I'm inclined to say this because it's so common, and I get it's the first question I get whenever I talk to a patient about surgery. They say, I don't want the mesh. And I'll tell them, well, unfortunately, you'll have to see another surgeon. I mean, we choose our patients very carefully, my partner and I. We are well above the curve in terms of our numbers for what we should be doing to be doing the procedures. But in 2008, a public health notice was issued regarding these complications of mesh, specifically transvaginal surgical mesh to treat pelvic organ prolapse and stress incontinence. Those are a lot of complications listed there. I will say that the majority of those complications are with a product with a company produced, which is no longer even utilized today. That was a different procedure, and it had a very heavy, thick mesh, which did produce a lot of scarring and a lot of erosion. The current products that we use today are much thinner. They're a little bit easier on the body, so to speak, and the rates are a lot lower. This data is obviously from quite a few years ago. And again, the FDA wants all the physicians to know that we have to advise them. I actually have the FDA handout that they administer to all the physicians, and I give that to the patients so they can know exactly what the risks are of the procedure. Why do we treat this? The quality of life is probably the biggest issue for me. Too many women come in saying that they don't travel, they don't go anywhere because they're afraid of leaking. They know where every bathroom is in the seacoast. I mean, although I don't have the other talk I give as residents, it's astounding how much money people spend on incontinence. A person who has pretty severe incontinence spends almost $3,600 a year on products. That's not to mention how much time you're spending, doing your laundry and avoiding social interactions with your family and friends. It really is amazing. All right, there's some guys out in the crowd, so we're going to talk about BPH. So incontinence is not only a female problem. I see plenty of guys in the office who have leakage of urine. So briefly, he was right. It's a walnut-sized gland that sits at the base of the prostate. And its only purpose is that it surrounds the urethra, this tube here, and it produces fluids along with the seminal vesicles that are a component of the ejaculate. The prostate makes something called PSA, which stands for prostate-specific antigen. It's a protein. It has only one purpose. The prostate produces a protein called PSA, prostate-specific antigen. It has one purpose, and the only purpose is that when you ejaculate as a male, it comes out of the ejaculate and it stays in the ejaculate in the vagina with the sperm, and it allows the sperm to stay motile and basically travel up the cervix. Otherwise, it has no problem except to cause men a lot of problems. And I mean a lot. BPH, I'll show you the numbers here. Half the men over 50 are going to be diagnosed with some form of BPH problem. The new studies show that 50% of men over 50, all comers, will have prostate cancer. If you did a pathological study, an autopsy study. It grows to its normal size in the man in the 20s and up to about the age of 30. Now, as species, most species in evolution, after they reproduce, they die off. Okay, so as humans, we're living longer and longer and longer. So a lot of these organs are becoming organs of atrophy, and that's what happens with the prostate specifically. And that's why we get these changes that occur that cause cancer, or an enlargement, which I'll show you next year. So the prostate can enlarge. It can become inflamed. If anybody has had or known somebody with prostatitis, it's a very painful infection of the prostate. Every time the urine tries to travel through the prostate, it burns. The movie The Green Mile with Tom Hanks, that's what he had. He couldn't pee throughout the whole entire movie. Watch it, you'll see. And then prostate cancer, which we're not going to go into that. We could talk about that for days, honestly. But each condition affects the prostate differently. The enlargement of the prostate, which we see most commonly in men, is what affects their quality of life, their activities of daily living, their avoiding habits, more importantly, their lack of sleep, getting up all the time at night. So BPH is simple. It's benign, which is non-cancerous, prostatic, meaning it's the prostate, hypertrophy, meaning the glands increase in size. Common names are an enlarged prostate, and it's growing larger than normal. The normal size is 1.5 inches in diameter. I've seen men who come in with a walnut-sized prostate who have off-avoiding symptoms. I've seen men who come in with a prostate the size of a grapefruit who have no problems at all. So everybody, as we know, is sort of rigged a little bit differently, and that's true to form with the prostate. When the prostate does enlarge, it's going to tax the bladder, and that in turn is going to lead to a lot of these voiding symptoms. I'll probably draw another diagram up there in a minute. First thing to know about BPH is that it's not prostate cancer. Although it's an adenoma is a growth. It doesn't necessarily have to be benign. It's also not a cause of prostate cancer. However, the symptoms can be similar to cancer. So it's sort of difficult as a urologist to say to somebody, well, your symptoms aren't definitely from cancer, just because of the statistic I told you earlier that 50% of men over 50 do harbor some form of malignancy. So you have to be careful when you're educating a patient or counseling them about whether it's the prostate enlargement or if it's a malignancy. And the PSA alone doesn't distinguish a benign prostate from a cancerous prostate. As a gland enlarges and gets bigger, it makes more of the protein. So if you have a larger protein, a larger gland, you're going to make more PSA. So your PSA is going to go up. If you have prostatitis or if you have BPH, again, that's going to cause a rise in the amount of PSA that's produced in the bloodstream. But that's really not the main purpose of the talk today. So this is the money picture here. Here's the bladder. Here's the walnut-sized prostate. Okay, the bladder fills up, very similar to this picture over here. Message comes back down. The bladder contracts passively. So when I go to the bathroom, I'm reading a text message or something. I'm not thinking about it. But some of the older gentlemen are focused in. You can tell them. You can tell them when you're out at the Red Sox game or something, they're nervous, and just sitting there. Don't go near them because they want everything to be relaxed. And stage fright is actually what happens when you have stage fright is it's adrenaline. So when you have adrenaline, the last thing you want to be doing as a species, as we are animals, is be going to the bathroom. So what it does is it closes the sphincter down. It keeps all the, you're not going to be defecating or peeing while you're in the wild being chased. So that's what happens when the poor guys are at the games. I leave cards at the truck stops. So the prostate size doesn't necessarily correlate with the obstruction. That's one thing that you have to learn. But in general, if the prostate becomes enlarged, like in this picture here, you can see that it's going to be harder for the bladder muscles to contract and push the urine through. So the first symptom of an enlarged prostate is a weak stream. And as men, like women, we'll say it's just part of aging. But there's a lot of progression that occurs in this, and that the fact that not only is the stream becoming weaker, the urine that's left over, what that's doing is that's kind of sitting right here at this little picture I drew for here. And that's telling this receptor down here, in this portion of the bladder, hey, I got to go to the bathroom. So it's telling the spine and the brain. And then all of a sudden the guy's going to the bathroom 8 times or 10 times a night, not because he can't empty out, but because the bladder still has a little bit left over here, which tells it to go all the time. And that's the principle behind nocturia. So the bladder functions to store urine, and when you have a bad storage problem, that's urge incontinence. And then it functions to empty urine. Women don't have a lot of problem emptying unless they have a cystocele. But for men, when the prostate's sitting here in the obstructed portion, that's where we come into a lot of problems. A lot of the symptoms here are the frequent urination, both at day or at night. The sudden urge to go. That's often first sign of urge incontinence. And that's when you know that your bladder is not emptying out completely. Okay, that's that message going to your spine and back up to your brain that it's time to go. And in some cases, the bladder is going to say, I'm tired of being full, and it's going to go. And then it'll have urge incontinence happen. Painful or burning urination, that is with a urinary tract infection. That's not necessarily because of an enlarged prostate. The weak flow is obviously because the system's obstructed, and that's causing the urine to come out slower. A sensation that the bladder is not empty, that's called the post-void residual, and that's what we talked about with the urine being left over here. When you have trouble starting and stopping, that's when you pretty much need to see a urologist at that point. Okay? You're not emptying your bladder out, you're going to be at risk for infections. Bladder stones, I don't know if you've had these, but they're very common. And then a urinary tract infection in the male is not a very common thing. So any male that has a UTI needs to see a urologist. Okay. Females, it's common because of the close proximity of the urethra to the introitus and all the perineum, but in men, that shouldn't be happening. So a lot of men who suffer from BPH say that it's a quality of life. Almost 95% of men with moderate symptoms. If you've been to my office or other urology offices, there's a questionnaire. It's called the symptom score sheet. It's very simple. It's got 5 questions. It's probably the most validated questionnaire we have in urology. If your numbers add up over to 15, you qualify as having moderate BPH symptoms. 95% of you that have that number are going to have a significant impact on your quality of life. The majority of these guys, it's getting up at night, or it's being on the golf course, having to go to the bathroom all the time. It's a nuisance essentially. Also, a lot of men who have prostate problems, have sexual dysfunction. I'm sure you've seen enough ads for Cialis. They managed to let the FDA approve them for both bladder problems and sex problems. Now, if a guy is having good sex, he doesn't care about his bladder problems. So, and it's true, if you look at the questionnaire, the guy's sex life's great, the symptom score for the bladder is awful, but he's very happy. How does this affect patients' lives? Some of these numbers here, so limit fluid intake before bed. That is probably the worst advice a physician can give to anybody. Why would you want someone to be dehydrated? It defeats the whole entire purpose. You want to always be hydrated. You want to be training your bladder. Okay? That's what you want to be doing with your urinary tract system. Avoiding places without toilets. I know that there are some people here in this audience who won't go to certain malls or certain locations because there's no toilet. If you go to the beaches in New Hampshire, Wallace Sands has a toilet there. You'll see a lot of elderly people there. It's true. You go to all the beaches in my Sleep. This is a big component here. People will always complain about daytime fatigue. Not only is it problems going to the bathroom, but it's also obstructive sleep apnea. Believe it or not, obstructive sleep apnea has a complex physiological loop that leads to increased urine production through some cardiovascular peptides, and that also can cause you to get up in the middle of the night. You can't drive for 2 hours, you obviously have a problem. And then again, avoiding outdoor sports, most guys don't care. They'll go to the bathroom anywhere. So, about 50% of men over the age of 50 will have BPH. Now BPH it's kind of a vague term because when you do a rectal exam, you only feel one portion of the gland. You really don't know what's happening on the other side. It's circumferential around there. So the only way to tell if someone has real BPH is to subject them to a transrectal ultrasound, and we just don't know. So those are based on some autopsy studies. But we do know that about 40% of men between the ages of 50 and 60 do have some symptoms of BPH. And almost 80% of men over 80 will have symptoms as well. I think obesity is linked to every single health problem we have in this country, so it's going to be linked to BPH. And obviously lack of exercise increases the risk of BPH. This is a no-brainer because you're going to be obese if you don't exercise. The diagnosis is principally performed, usual medical history will help out, as well as the physical exam. I would say that after you do enough rectal exams, you can tell that there's definitely an enlarged prostate, but a lot of sort of patients who come in with a lot of voiding symptoms, the primary care doctor notes may say, oh, normal digital rectal exam. But when you do a cystoscopy or you look into the urethra, they have a very large prostate that's causing some symptoms. So just relying on the rectal exam for a lot of voiding dysfunction on men is really not the best approach. If you've been to a urologist or to my office, we do these peak urine flow tests. We ask you to drink a lot before you come in. You can always tell the guy who's coming in for the uroflow test, he's ready to go. He's bouncing around. It's always his best flow too, because his bladder's up to about here and he goes. And then we also want to really measure this post-flow residual. And that's the urine that's left over within a large prostate. That's going to cause a lot of symptoms. Symptom scores, these are these questionnaires that you can get online, and I give out to all of my male patients just as a baseline. If we do any intervention with medical therapy or surgery, we always like to have something to look back upon for 6 months or a year down the road to see how their symptoms are or not improving. Treatment options are pretty variable. Alpha blocker therapy and 5-FX inhibitor, this is Flomax and finasteride. Again, marketing, weekends, these are always going to be on the TV. Most men are watching TV. These help the bladder to relax, an alpha blocker. It also helps the bladder to shrink. It's a first-line therapy. Some patients cannot tolerate an alpha blocker because they're already on hypertensive medications. So you'll get very dizzy and syncopal, and you can faint from the alpha blocker. The 5-FX inhibitor actually shrinks the prostate over the course of about 6 to 9 months. Very few side effects. It can cause some breast tenderness or change in libido. Surgery, which I enjoy doing, includes a microwave therapy, which we don't do that anymore. The laser, this is a point that I want to bring up in a minute. So a transurethral resection of the prostate simply means that you're going to go through the penis with a camera in some form of energy to open up the prostate or do what's called a roto-rooter. It can be done with a regular.
Let's see.
I can't show the video. There's a lot of different energy forms that can do this. There's traditional cautery, which basically uses energy to resect it. There are lasers that you directly contact the tissue with that actually then vaporize it. And then what almost everyone is doing, and at the last AUA meeting it's kind of become the gold standard, is what's called the green light procedure. Now, if you think about it, any man over 50 has BPH, so we could do this in everybody, but that's really not the way that surgery should be performed. You should basically exhaust your medical therapy before you consider having surgery, and that's the way that I've been trained, and that's the way I'll continue to treat patients. Patients will come in saying, I want the green light. I haven't even examined them or done anything, and they don't even need it. It's a procedure that doesn't need to be done unless it's necessary. Why is the green light so important? So the laser fibers are attracted to certain wavelengths. The good thing about this laser fiber is it's attracted to the tissue that's the same wavelength as blood. So there's a significant decrease in the rate of bleeding. For those doctors here that used to know that when you did a TURP 10 years ago, guys stayed in the hospital for 3 or 4 days because they kept bleeding from their prostate until it finally healed. 50% of patients who have a green light laser go home either that day or the next day. So that really has revolutionized the way you can treat large prostate. An open prostatectomy. If someone's prostate is the size of a grapefruit, trying to do a roto-rooter is going to take 5 hours. And in the meantime, you could have done about 4 open prostatectomies and simply taken the prostate out without harming the sphincter or the nerves, just taking it out of the core. So we do those in some situations where the prostate is too large. The AUA, which is our abiding governing body, says that there's no dietary supplement or combination phytotherapeutic agent or non-conventional therapy that's recommended for LUTS or lower urinary tract symptoms secondary to BPH. This includes saw palmetto, urtica, diosine. So I disagree with this completely. Saw palmetto, which is the main component of a lot of these beta prostate pills, which you may see if you're up at 3 in the morning, the Joe Theismann commercials on. The stuff works. It's been studied by the VA Center in San Francisco. There was no negative side effects from the medication. The data wasn't statistically significant. So in medicine, if it's not reaching a certain number, it's useless. I don't agree with that. All the trends were pointing towards it being helpful. My friends down at Boston Men's Health, who deal with a lot of men's health issues, all prescribe it. So there's no side effects. You can get it at Walmart. I have young guys who have prostatitis or other problems on it, and it really is beneficial. So I don't have to agree with everything that I read up on. So watchful waiting or medical therapies, those are for patients who have the symptom score around 15 to 7. These consist of exams, following how they're doing, Again, that symptom score sheet is very important. You can modify some of your, the diet's not going to affect it. The evening fluid thing I disagree with. Essentially, in these patients, it's more watchful waiting. At some point, it's going to be the situation where the gentleman's going to say, I really want to do something about this. And at that point, we'll talk about whether it should be surgery or not. The medications that were briefly up on that slide, these are for men who have severe symptoms. It's true about alpha blockers. Any man, I've tried a lot of medications in my practice. I've never tried this, but I bet you if I took this for a week, I would notice a significant difference in how I pee. So most men will come in 1 or 2 weeks later after trying tamsulosin or Flomax, and they'll say, man, it's great. We can double the dose and they'll even be better off. Triple the dose, it doesn't matter. The side effects, the drop in the blood pressure is very important. A lot of our friends who are elderly are on Coumadin and Plavix, and now they're on these medications like Eliquis, which you can't reverse them. So if they fall down because you gave them a medication help them pee better and they have a head bleed, it's not going to look good. So you really got to monitor what these patients are taking. Nasal congestion occurs. Flomax is the exact opposite of Sudafed. Okay, so people take Sudafed to close down the vasculature around the nasal area when they have upper respiratory tract infections. Every year, 2 patients will come into the ER in retention. Why? Well, I tripled up on my Sudafed. Well, you tripled up on your prostate closing down as well, too. When you ejaculate on Flomax, the ejaculate will go back into the bladder. Most men on Flomax are over the childbearing age. Therefore, it's not an issue. Drug interactions are specifically interactions with other antihypertensive medications. Atenolol, Ozar, those medications. 5-alpha-reductase inhibitors actually shrink the prostate. I find that a lot of patients might be started on this, but unless your prostate is at least 40 grams or larger, which is about 25% larger than the normal gland, this medication has no use. So if you're on it, or someone's telling you to be on it, you have to make sure that you have a large enough gland that will actually be beneficial. It does reduce the risk of the need for surgery for a couple reasons. It reduces the size of the prostate over the course of 6 to 9 months by almost 20 to 30%. It also decreases the vasculature to the blood supply to the prostate, which is very important because when we operate during a TURP, we prefer if it's not bleeding. It makes the procedure go better. And that's helpful as well if we do the procedure. Erectile dysfunction and impotence can occur. It will cause some patients to have a lower sex drive. Ejaculation disorders will also occur. And this one fact here is that it lowers the PSA. It's actually going to decrease the size of the prostate by 40%. So the normal protein that's being made, that's going to go down as well. So you have to take that into consideration if you're on finasteride and you're following someone's PSA. So a TURP is a procedure that goes in and opens up the channel. That's a thin metal band that is basically cauterized or it's hot. And it's intended for men with moderate to severe symptoms. General anesthesia can be used. These guys stay in the hospital for 2 days. Quality of life scores are improved. Almost everything is beneficial. The side effects can include some retention in the operating room. You can have erectile dysfunction. You can have retention. You can develop strictures. You can develop a lot of scarring that can occur as well. I got to fly through this here. The lasers are typically the same principle as the Roto-Rooter, but what they're done is in an outpatient setting, there's a minimal amount of blood loss, and the side effects tend to be less for most patients. Open prostates, that's an open procedure done, general anesthesia, little incision, removes the prostate. Insurance covers, it should cover everything, we pay enough of it. So in general, the prostate works and enlarges in the BPH. It causes a lot of these obstructive symptoms that are manageable with medication or surgery. And if you want to talk to me or my colleagues about any of these issues, we'd be happy to. Thank you for your time. I'm sorry I went over.
Any other questions?
Thank you.